y'all, it's me, Dr. Smearmon, Gyno Girl, coming at you to discuss an important topic that I'm very passionate about, and that's the fourth trimester and postpartum healthcare. Specifically, though, I'm going to focus on postpartum sexual dysfunction, sexual health, and how this is oftentimes dismissed and needs better attention. So let's get at it. Hey y'all, it's me, Dr. Smearmon, Gyno Girl. Thanks for joining me today. I'm going to talk about a very interesting topic that's near and dear to my heart. Is postpartum fourth trimester sexual dysfunction. I am a sex med gynecologist in downtown Chicago with my own private practice. I see patients in all phases of life, many of them with issues around sexual dysfunction, whether or not it's desire, arousal, pain, or orgasm difficulty. I'm also a midlife specialist for menopausal and perimenopausal women. And I'm here to help you guys by educating a little bit, learning, and I've learned a lot from my own patients, and so hopefully that you can advocate for yourself. I've launched a podcast in the last month or so, almost 2 months now, called Gyno Girl Presents Sex, Drugs, and Hormones, where I interview patients of mine, I interview other clinicians and experts in the field, and we get into the discussions that maybe you're not having in your office and discussions that you should be having. So it's very important for me to get this information out there for you guys. Please like and subscribe to my channel. I'm very excited to be here today to talk to you about the fourth trimester and fourth trimester care, which is a very underserved and under-recognized arena. I think only about 40% of women after they deliver even go in for a postpartum visit. I've had 3 postpartum periods of times in my life because I have 3 kids, and I have to say, I never went in for a postpartum visit. Okay, so I'm number one culprit, which is a big no-no. But in 2018, the American College of OBGYN kind of redesigned how they wanted to look at postpartum care. Because right now, as it works as a system in the United States, your insurance, it covers your initial visits and I think around 10, I don't deliver babies anymore, so I don't know for a fact, but I think it's about 10 visits with your OBGYN or whatever type of clinician you're choosing to have your baby with. The delivery, the postpartum visits in the hospital, which is anywhere from 2 to 4 days or 1 to 4 days even, sometimes longer depending on complications, and then 1 postpartum visit. And that's bundled in a global fee. So insurances have made it very difficult for patients to get the care they need in the fourth trimester. Clinicians also, because many times do not get paid for fourth trimester visits, will oftentimes not emphasize them enough. If you go to a busy OBGYN practice, where they see 30 or 40 patients a day and really trying to cover their overhead, trying to deal with all the patients that they're seeing. Many times the postpartum visit is one of the most neglected. So we're trying to change how we deal with patients in the postpartum. Obviously, postpartum depression has to be screened, on postpartum birth control and discussion around that, higher feeling in general, higher coping. I mean, it's a big life change, right? Having a baby is a huge life change. It's wonderful for so many people, but oftentimes can be very alienating and isolating, particularly if you don't have sufficient help. In many countries around the world, patients, after they deliver, will go either to their parents' house and stay for 40 days or have additional people come help them. And it's very much a part of the culture in those communities to help patients recover from this very life transformative event, which is where you deliver a human being out of your uterus. So I think that in the US, we haven't figured it out yet. We don't have the right way for patients to postpartum here, for the fourth trimester. It's a very neglected period of time. Women neglect ourselves. Like I said, I'm a culprit. I'm never going in for my postpartum visits because life gets busy. You're trying to navigate potentially nursing or versus breastfeeding. You're trying to navigate a new human being that's keeping you up at night. Crying, you're trying to navigate your new body because the bounce back culture in the United States is real, encouraging women to bounce back to normal, which I do not agree with. I think that it takes a long time for you to feel comfortable in your body and to really feel like sort of yourself again. And so when I see a patient in the fourth trimester, I'm always trying to evaluate all these things for mood disorders, for issues around the pelvic floor. Every one of my patients that gets pregnant and they come back to me postpartum because I don't do obstetrics anymore, I will focus on fourth trimester health, including postpartum pelvic floor dysfunction. We know even if you've had cesarean sections, the weight of the pregnancy on the pelvic floor can impact your ability to hold your urine. And depending on what type of tear or laceration that you have in the fourth trimester, can impact the amount that you recover. You're compounding that with your hormones going from a high level to really declining, especially if you're nursing, you're losing a lot of estrogen, and that is being suppressed. And what happens when estrogen is suppressed in your body is you kind of end up in like a perimenopausal, postmenopausal state. So the things that happen to your vulva and your vagina are similar to what happens to women when they go through perimenopause and menopause, particularly when you're lactating, when you are breastfeeding. So you not only have the issues around your breast feeling strange, and a lot of us, when we used to pump all the time, feel like we're just cows pumping out milk. I think at times I felt like that, but it's also a beautiful thing to be able to do if you're able to. We also, I think, pressure patients so much that when they can't, it becomes challenging. So I always give my patients grace and mercy when it comes to that. And so you have those issues, you have the mood disruptions, you have the hormonal disruptions, and then just the recovery, right? The recovery is huge. You just create a human being and it's out of your body now, and while you're pregnant it was this great thing. You felt like, I have this nice pregnant abdomen. People think you have this pregnancy glow, and then the baby comes out and the focus does become more on the baby, right? That happens in probably everyone's life, and women often feel dismissed, that there's not as much concern around how you're doing or how you're recovering, from friends to families and everything else. So if you don't have an adequate network of support, we still know that when patients become mentally disrupted postpartum, it can lead to some of these mood disorders, which then can lead to many other problems for patients, including anxiety disorders and panic disorders, postpartum psychoses, postpartum depression, and even postpartum suicide. So these things should be evaluated for in the office. These things should be assessed on a few weekly basis, particularly if you are positive, and to get some patients in for that. There's a whole idea of your sexual function, right? When I trained in OBGYN, the only thing we learned to ask patients postpartum was what type of birth control are you going to use, because we used to encourage patients not to get pregnant right away. So the birth control aspect was just the biggest thing. But very little was asked about when patients were able to, after they'd healed, whether or not they had sexual pain, whether or not their libido, their arousal, or their orgasm function was intact, which changes for a lot of patients in general. The research shows that 89% of patients, when they reach about 6 months postpartum, are engaging in sexual activity, but the degree of sexual dysfunction is pretty prominent. 40% of women at some point in life have sexual dysfunction issues, whether or not it's libido, arousal, orgasm, or pain. Patients in the postpartum, it's about 64% by 6 months that still might have some arena of sexual function that they're not satisfied with. So if you compound that with all these other issues around sleep, around disturbance, around not feeling like yourself in your own body, the healing of the postpartum, right, when it comes to either cesarean sections, it's a major surgery, you're healing from it. But also when you have a vaginal delivery, you can have a normal vaginal delivery, you can have an instrument-assisted vaginal delivery, which can be forceps or a vacuum. And those things have a varying degree of impact on your healing. Patients that have operative vaginal deliveries tend to have longer healing and sometimes more difficult healing. Oftentimes with those deliveries, you might have a larger laceration in the vagina. When we have a first-degree tear, really just the superficial vaginal skin. Second degree goes into the muscle, third degree goes into the sphincter and below, and then the fourth degree all the way through the rectum. So we're talking about these higher levels of lacerations that can lead to a lot more of a dysfunction. So when I see a patient in the fourth trimester, I try to review all of these things. I try to get under all of these things, asking them if they have help, trying to make sure that if they want to breastfeed, and that is a goal of theirs, if they get some lactational support, looking at the pelvic floor and getting them into pelvic floor physical therapy by 8 to 12 weeks postpartum, depending on how they are doing. And then getting into the sexual function issues, right? So, of course, trying to figure out if they have a plan for contraception is part of that, and that's probably the only part you learn. But when, like I said, when women are lactating, they tend to diminish their estrogen production, and it creates something similar to the genitourinary syndrome of menopause. Most of us in this field think we should call it the genitourinary syndrome of hormonal deficiency, because it is more of a syndrome of hormonal deficiency that can be experienced at different parts and stages in life. So pelvic floor therapy is integral to sort of healing. We're looking at the degree of lacerations and how they're healing and making sure that's not any issues around scar tissue or other things that are causing pain. One of the most common reasons of sexual pain is that genital urinary syndrome hormone deficiency. That includes that lack of estrogen when lactating, when breastfeeding, and what you end up having is more concerns around the vulvovaginal opening again, that vestibule. Remember my vulvar puppet that I always bring up? The vulvar vestibule is that area from the inner labia minora to the vaginal opening, this thin area of tissue that is both estrogen and testosterone receptive. And so we have patients who have that thinness in the vestibule, their redness, and the thinness of the vagina, and the changes that are consistent with low estrogen, including a less collagen production, less normal discharge, and also issues around elasticity that can develop. So patients end up with significant sexual pain at insertion, and then sometimes even deeper than that if the pelvic floor is not healing. So pelvic floor physical therapy is key. Some patients will need that for an extensive period of time, and I have a great therapist, Steve Grace. She sees all my patients in the 4th trimester. And then many times we will give vaginal estrogen, just like we do to postmenopausal and perimenopausal patients. I will sometimes incorporate that estrogen testosterone ointment cream that I use in patients where I think they have a hormonally mediated pain in their vestibule, in that opening of the vagina, this area between the inner labia minora and the hymen remnant extending all the way around the urethra tube and the periurethral glands. So that is super important to make sure that we're getting hormone there. And then when deciding about birth control, that is sometimes an important thing to remember as well. So sometimes we'll promote intrauterine device so that we don't get much of that systemic changes that will further contribute to issues around the vulvar vestibule. So that's that. And then we really look at whether or not arousal has changed, orgasm has changed. A lot of men go through their own changes. If your partner is a male, they go through their own changes when they have a new baby. The lack of sleep hits both mom and dad in the same in different capacities, depending on how engaging and what their role is of each individual and what you've decided and how one person may help the other. So in postpartum, 4th trimester sexual dysfunction is real. It is common. It is multifactorial. It is related to sort of how you feel about your new body and the issues around that, how you're feeling about breastfeeding and the changes that occur in your breast. That can be a really erogenous area for some patients, and that changes a lot. So that also contributes to some sexual dysfunction when it comes to wanting to have intercourse with your spouse or your significant other. And so we have to address those areas. We have to address the pelvic floor. We have to address the hormones related to the lack of estrogen production when you are lactating. And we have to get patients in different types of therapy if they need it. If someone is suffering from anxiety or depression, I always give my patients a questionnaire called the Edinburgh Postpartum Depression Scale. And these are the questions that we ask, as you can see. So I'm trying to get them into different types of therapy or medication if they need it, and then working with them specifically on things that are hindering their sex life. One of the biggest hindrances I tell patients is like the lack of a chance to have a date night or to have that intimate moment with their significant other again. And that's because now you have a crying baby, right? So you have to work on these. You have to get a date night. And sometimes that's not something that patients can do, right? Sometimes it's not something that we can do because you don't have the extra help. You don't have the extra assistance. You don't have a nanny or a family around that can help you. So these things have to get into place in order to have successful relations again. And most patients do suffer quite a lot and often are not asked enough. So if you're a provider or clinician listening to this, please start asking, please start working with your patients. Please send them to a pelvic floor therapist if you don't have one in your own office like I do. If you are a patient who is suffering from postpartum issues, whether or not it's lactation, whether or not it's depression, anxiety, whether or not it's postpartum sexual dysfunction, whether or not it is issues around hypoactive sexual desire disorder and low libido that can happen for multiple reasons, or whether or not it's sexual pain or any of these other factors, please seek help from a clinician or a provider that can really help guide you through this journey. Actually, it's a life transformative journey, and most patients are really grateful they got to experience it, but it is neglected, and patients are often neglected as well. So we have to do better for everyone. This is an article I wrote right after I had my last child, who you sometimes see on my social media, Zoya. She's now 5, and so I wrote this 5 years ago in 2019. It is called Postpartum: Why Women Don't Get the Sexual Health Care They Need. And I think that it was an opinion piece I wrote for Scientific America, and just talk about the disservice that women experience in the postpartum period. But it is a passion project of mine. I hope that if you're postpartum, you can get help. And I hope that if you are a clinician that treats women who are postpartum, that you will ask about their sexual function. So thanks again. Please like and subscribe to my channel. This is Dr. Smina Gyno Girl, and I will see you next week. Thanks so much.